Before Karthik opens, I will just, we are about to discuss one hepatocellular carcinoma. And I will briefly discuss this history of this patient. He actually evaluated for low back pain, where on CT scan there was diagnosis of lytic lesion in D11 vertebra, for which he was stabilized, and HPR revealed hepatocellular carcinoma, that is metastasis from the hepatocellular carcinoma. And on further evaluation on MRI liver, which showed some 5 centimeter lesion involving segment 8 and 1.1 centimeter lesion in segment 2. He actually came to us, so after tumor board discussion, multidisciplinary tumor board discussion, we advised him this proton therapy, and also he has a history of chronic liver disease. And keeping in view of background of chronic liver disease and sparing with the intent to spare the normal liver, the liver minus GTV, and simultaneously to treat both the two liver lesions and the spine. So we opted for proton therapy, and so after once he is selected for proton therapy, we have institutional protocol to call all GI patients. So we call all GI patients with 4 hours of fasting, keeping the stomach empty. So Karthik will say what we do the simulation purpose.
Okay, for the simulation purpose, for all liver cases, we do a backlog, or we call cushions. As I told you, we get a very good contour of the outer surface if you are going or approaching towards the posterior side. And most of the times we approach in the posterior side, but it depends on the site of the target. Anyway, so, and from my yesterday's presentation, you can see that till date we have treated almost 7 liver cases, out of which 6 we treated with breath hold, because we know liver moves a lot. So for this, upfront we go for a 4DCT, we check the motion, we evaluated the motion was around 1.5 centimeters, so we cannot go for a free breathing planning. So immediately we started to opt for deep inspiratory breath hold. So as per protocol, we have, for this patient, we have to coach him almost 3 days to get the best reproducibility of the deep inspiratory breath hold. But ultimately, we made sure the reproducibility of the deep inspiratory breath hold is around 3 to less than 3 millimeter. Okay.
This
so
is also
out
a patient
of all,
in whom the feedback goggles were very helpful.
Yeah.
So feedback was very helpful to actually get him to hold the breath in the same consistent pattern throughout the treatment duration.
So morning someone mentioned about feedback goggles. So for this patient we have used it because this was useful for this patient, but there are few patients which they became very much anxious and they are very much conservative or seeing to that, and they are not doing the good. So depending on the breath hold or depending on the reproducibility of the breath hold, we evaluate if feedback goggles are required or not. For this patient, it was required.
In fact, if patients are being planned to send over, I usually tell them to start practicing breathing exercises like pranayam. If patients are actually already doing, people who are used to doing pranayam, they are able to hold their breath consistently and reproducibly at the same level quite easily. So if they are not somebody who's used to doing that, we do advise them to start practicing that, because it helps by the time they get to simulation, they are able to understand what they need to do and what level they need to hold at.
And before going into that, here we can see the segment 8 lesion is 5 centimeter and it is very large. But the segment 2 lesion is very small, and as a purpose for matching purpose, it is very difficult. There are no anatomical boundaries nearby to match. So we have inserted one fiducial. That is what we inserted here is a gold fiducial. Karthik, can you add to it? Why gold?
Yeah. We have used this gold fiducial because we know all the dimensions as well as composition of this particular gold fiducial. We have started this gold fiducial for our prostate cases in initial time. Then we stopped because of the size. Because when you go for a gold fiducial and take a CT, these fiducial dimensions are around less than 1 millimeter dia. Okay, but in this image, you can see this comes around 2 to 2.5 millimeter of dia. Sorry.
So we have not used fiducials in most of our cases. Some of the cases where we don't have any anatomical landmarks nearby, because most of the cases we get are actually large tumors and not very small ones. This was a particular case in which we had a small one additionally, and so that's the only reason why we used a fiducial. We normally don't need to use fiducials.
So being a very small tumor, we have allowed and we went for a gold fiducial.
Okay, in the meanwhile, we had the institutional protocol, what I said. During simulation, we call the patients with 4 hours of fasting, keep the stomach empty, followed by which 20 minutes before the scan, we give neutral Mandel-based oral contrast. I will tell you why in the next few seconds, like why we use that. And followed by which, after 20 minutes, we take one normal free breathing scan. So as we have already trained the patient with DIBH, with the breath hold, followed by free breathing, we take one breath hold scan and one more breath hold scan after 3 hours or on the next day to see the residual or whether it is able to reproduce it or not.
Yes, this will help us to get the reproducibility and maximum time to practice to the patient.
We also give IV contrast for target delineation. We take triphasic CT scan, and so that registration also will be good if we have done in breath hold.
Yeah, we do all the contrast-based scans in a deep inspirative breath hold. Okay, now we are on. So for this patient, because it's having 2 lesions at 2 places, so what we have done,
So just
for
as
target
an
delineation.
additional point, the MR planning is also done in order to help us with target delineation. That is done separately. All the contrast scans are done last, and one of the breath hold scans, I told you we do it on 2 days or on the same day at 2 different sessions. One of the breath hold scans is designated as the planning scan, and that is the one which is used for target delineation.
So for target delineation, we fuse with the
Yes, we do all 3. Plane scan for planning, contrast scan for target delineation, the CT, and additionally we also use the MR for target delineation.
So targets are delineated as Dr. Ashwati said with after fusing the MR. So the CT, the gross tumor volume, the segment 8, we labeled it as GTV1 and the small lesion GTV2. Though we have given a small margin like 3 millimeters of margin from gross tumor volume to for actually uncertainty in target delineation. To cover that, we have given 3 mm margin. And we have also seen the residual motion in the breath hold is not more than 3 mm, and we have generated ITV also of a 3 mm from this CTV.
so on the basis of this ITV, for this patient, we went for a CTV or ITV based robust optimization, but we managed to plan this with SFO technique. So what
Before,
we have done,
Karthik, before going to this, as I previously said that there is a D11 spinal lesion also. So we want to treat simultaneously both liver lesions and also the spinal lesion.
I think so is everyone. That's a nice way of putting it, ma'am.
So simultaneously we need to treat the spine and also the liver lesions. So we know that the liver minus GTV and he is a patient of chronic liver disease and we have to save as much as the liver possible. And for this patient that how we achieved the liver minus GTV with the dose constraint, we prescribed as mean liver minus GTV dose to less than 20 gray. 20 gray. So Karthik, can you show how the beam arrangement you kept and
So for this patient, as I told you, okay, we tried to do this very irregular two-sided, means 2 targets. That too, we managed to do a SFO-based plan. So we used 4 beam technique, out of which this posterior oblique, lateral and anterior oblique of right side are treating to only the big target of the liver, this side. And this anterior oblique of both right and left are treating to the small target. But we try to maintain the SFO technique. Okay. And it is robustly optimized to the CTV.
So the dose
Now-
prescription
now-
was 67.5 gray in 15 for the liver lesions, which is the standard protocol used in the phase 2 trials in the US. And for the spine, we limited it to 45 gray in 15 fractions.
And we have intentionally underdosed towards the duodenum to spare the duodenum dose to the level of almost 40 gray. So duodenum, almost in the range of 15 gray because of.
So as with all liver cases, the GI structures take first priority. And the beauty of this plan is that the liver contribution from the spine plan, the doses to the liver from the spine plan are negligible. Similarly, the doses to the spine plan from the liver plan are also negligible. So it's essentially like treating both of them, but from two different directions with basically no overlap between the plans or very minimal overlap between the plans.
At the same time, we can manage to achieve the liver minus GTB to a dose of 20.6 gray mean dose.
So if you see the low and intermediate dose isodoses, so that is a 15 gray isodose, and if you go, can you scroll superiorly?
Yeah.
So there's virtually no overlap between the or bridging between the isodoses, which is very difficult to achieve in a photon plan. And we have a comparison
We have a
plan
complementary
also.
photon plan, so we want to.
In the comparison photon plan, actually the mean liver dose constraint was not able to be achieved, so we probably would not have been able to treat this with a photon plan if we wanted to.
Yeah, you can see over here the liver minus GTB dose achieved with the TOMO was around 34 gray, whereas we can manage to achieve of 20.6 gray with proton with same dose of 67.5 gray to the target. So apart from that, as Dr. Nagarjuna told, we want to treat the spinal cord of this area. So for the treatment of spine, and it is having a lots of metal inside. So as a department protocol, for all the metal implants, we go for a MBCT always, and along with that, a KVKV to know the shape of the metal. Because sometimes in the CT, you will have a deformed shape of the metal. So we have delineated this, and we take another CT because we no need to treat this area with DIPH. Okay. So what we have done, we have.
So the spine plan is treated in a free breathing situation. So we first implement the treatment of the liver in a breath hold, and after that patient can relax and the spine is treated in a free breathing situation.
So to tell you, for the spine, we have used very simple two posterior oblique beams, and they have treated to a dose of 45 gray. At the same time, restricting the spinal cord dose to
Less than
31 gray.
Okay. Can you please show the combined plan?
Yeah.
And also the load
So,
assess?
as you see, both the targets are coming in the almost in the same place. So it's better to see the combined plan of the both, because there may be some contribution of the spine plan towards the liver plan. Sorry. Oh, I cannot say over here. So now you can see over here, this is the spine plan, and this is the combined dose of both the spine as well as liver. And you can see there is a small area where it is getting extra 15 gray. Otherwise, nowhere we have a dose contribution from one plan to the other plan.
So where it is very much difficult to get it in a photon plan.
Yeah, it's very, very difficult to get it the same in a photon based plan. So
any questions about implementation? Like I mentioned, we implement the treatments in a deep inspiratory breath hold. Karthik, do you want to go over the implementation?
So for deep inspiratory breath hold, what we use in our APCC, first we will take a surface guidance reference, and on the basis of the surface guidance at the deep breath hold condition, we take the CBCT. Okay. Once the CBCT was matched with respect to the planning CT, we apply the delta values and take a fresh reference. And under that fresh reference, we want to replicate the same breathing pattern and we want to deliver. So it is always deep matlab DIBH based imaging plus treatment.
The first day we sometimes do repeat cone beam also to again ensure that it's what we have corrected is also correct. But on subsequent days we are able to manage with a single cone beam. So generally when we screen patients for breath hold, we try to make sure that they're able to hold a breath to at least 20 seconds, because it takes 20 seconds or 30 seconds for one cone beam. So that's the limitation that we make sure that they're able to hold at least till 20-30 seconds. So I think we'll move on to the next case. If there are no questions, we'll just move on to the esophageal cancer case. Nag,
so next, the esophageal case, the history. She is a 55-year-old lady, actually evaluated dysphagia for the solids, where the upper GI endoscopy lesion showed the mid-esophagus lesion. So as a standard guidelines, we have contoured the gross tumor volume, and we have given a margin of 3 centimeters superinferiorly and 1 centimeter radially.
So we are treating her to preoperative chemoradiation to 41.4 gray in 23 fractions. And this is just to show you the extent of benefit that you're going to see to the heart and the lungs in terms of dosimetry.
Okay, for all the esophagus cases, as per my presentation, all our esophagus cases we treated with free breathing, because with 40CT evaluation, we always get it is less than 5 millimeter. So for this patient also, we took a 40CT and we evaluated, it was around 4 to 5 millimeters. So we go ahead with the free breathing planning. So for this patient, we have used a very simple technique of 2 posterior oblique beams. So we use 2 posterior oblique beams in SFO technique, and the doses to the heart, the mean dose was around 10 gray. At the same time, the total lung V5 was 42%, whereas the V20 was 15%, while treating it to a dose of 42.4 gray, 41.4
The
gray.
mean lung dose was also only around 8.75 gray. So, I mean, this is just to compare with our existing experience of photons, where the doses are definitely not so low.
Karthik will show the comparative.
So,
and you can see the low dose and intermediate dose clouds are quite different in terms of the comparison between a photon plan and a proton plan. So the positioning of the beams is also why we are so persistent about the immobilization being very important as far as the treatment is concerned. Because throughout the treatment, when we are using posterior beams, we preferentially use posterior beams because the posterior surface will be the most reproducible, the least likely to change during treatment. Even with weight loss a little bit, if you are putting anterior beams, it is likely to impact much more. Plus in abdominal and thoracic abdominal tumors, when you use anterior beams, you will be likely to go through bowel, which may be filled with gas one day, which may be filled with, which may be empty another day. So using posterior beams or lateral beams actually helps you eliminate all those uncertainties in a very simple way.
And anterior beams will pass through the heart, which is a very moving organ. So that's why we avoid that. We generally go for 2 posterior oblique beams, and it is more than enough, and it is all the people follow this beam management for esophagus cancer.
So here see in the tomo plan, the average dose is like 20 gray, where in heart 10 gray.
Thank you, Nag. Thank you, Dr. Karthik.
Spinal cord dose.
Spine cord. Oh, okay. The spinal cord dose is little higher side, but it is well within the limit. Anyway, I will show you.